is Dr. Chitra, a mentor at StudyMEDIC and StudyMRCOG, and today we are going to discuss the module Pathology. So in pathology, what I found when I went through the previous papers that there are a lot of questions on oncology, most commonly on ovarian cancers, and the next common is vulval. So we would be discussing everything related to those cancers. Now a typical SBA would look like they would be giving you the photograph of a characteristic histopathology of a tumor, and you would be asked to identify the tumor. So what looks like you have a structure like a glomerular-like structure which is composed of a central blood vessel enveloped by tumor cells within a space that is also lined by tumor cells, and this is called as the Schiller-Duval body. So in which tumor do you expect to find this structure? So the correct answer is endodermal sinus tumor. Now endodermal sinus tumor is also called as yolk sac tumor. It is the second most common malignant ovarian tumor of germ cell origin. It resembles extraembryonic yolk structures and it produces alpha fetoprotein. Now this tumor in the ovary is analogous to endodermal sinus tumor of the testis. That means yolk sac tumor in the ovary is analogous to endodermal sinus tumor of the testis. So this is the typical histology that you would see. Here I am showing you two pictures. So this is the Krukenberg tumor. Now in Krukenberg tumor, what is seen? You have signet ring cells. If you can see this, this is actually the signet ring that is here. And if you see the cells here, they have a foamy cytoplasm and the nucleus is pushed to one side. So these are cells. These are seen especially with Krukenberg tumors of the ovary. The primary in these cases is usually the GIT followed by the breast. Now in the picture on your right, you can see the Schiller-Duval body, and in the center you have the blood vessel which is lined by flattened tumor cells, and beyond that you have fibrin or fibrosis. Now next, coming to the next common picture that you would have. So what is this? These are Karl-Exner bodies. They are seen in granulosa cell tumors. So what are these Karl-Exner bodies? They are small eosinic fluid filled punched out spaces in between the granulosa cells. So when do they present? Like when do the granulosa cell tumors present? You can have them at extremes of age. So 5% of them before puberty, 60% are seen after the menopause, and since they are estrogen producing tumors, they give rise to symptoms of estrogen excess. So they can present as an abdominal mass with symptoms of an ovarian tumor. They can, if seen before menarche or before puberty, they can present with pseudo-precocious puberty, and they can, if in the reproductive age group, they can give rise to menstrual disorders. In postmenopausal age group, because they are estrogen producing, the woman can present with postmenopausal bleeding. Now what is this? So this is typically a coffee bean nucleus that is seen in Brenner tumor. Now Brenner tumors are basically benign. 5%, they constitute 5% of benign ovarian epithelial tumors. The age at presentation, it's a very wide range, 30 to 60 years old. Majority are asymptomatic, very small tumors, less than 2 centimeters, and they are discovered incidentally. 7 to 8% of them are bilateral, and the histology that you could see is there are nests and islands of epithelial cells with a centrally grooved coffee bean nucleus. What are these? These are Reinke crystals, and they are seen with Leydig cell tumors. So Leydig cell tumors are rare ovarian tumors. They are steroid producing neoplasms usually seen in the postmenopausal age, and they can lead to androgenic manifestations. So occasionally they can produce estrogen, and because of unopposed action of estrogen, they can lead to endometrial carcinoma. So these Reinke crystals, basically they are rod shaped inclusions that you can see. They are eosinophilic, so they appear pink color on the slide. What is this? Well, these are Samoma bodies. Where do you find Samoma bodies? They are seen in PSM, not the subject PSM. So P stands for papillary carcinoma of the thyroid, S is serous pseudocystadennocarcinoma of the ovary, and M is meningioma. Remember, some Samoma bodies are made of calcium and they are characteristic spherules seen in the above tumors. Okay, so because they are made of calcium, they are also called as calcospheroids. Next, coming to the tumor markers. Okay, so a typical scenario would be that there is this 18-year-old woman who has presented with a large solid ovarian tumor. Tumor markers were done and LDH was found to be elevated. So what is the likely pathology of this tumor? You have the following options. Now remember, young age, solid ovarian tumor, LDH. The first thing that should come to your mind is a dysgerminoma. And as you guessed correctly, it's a dysgerminoma. So what are the tumor markers that are commonly done in premenopausal age group? Remember, in postmenopausal, because the tumors are mainly epithelial tumors, it is CA-125 that is done. In premenopausal, they could be germ cell tumors. So the tumor markers that are done are alpha fetoprotein, HCG, and lactate dehydrogenase or LDH. So dysgerminoma doesn't produce alpha fetoprotein. It could produce HCG and it may or may not produce LDH, but LDH is very characteristic of dysgerminoma. Now immature teratoma, because it has all the germ cell layers, it produces alpha fetoprotein and LDH but doesn't produce HCG. HCG will only be produced whenever there is trophoblastic tissue. Yolk sac tumor or endodermal sinus tumor, it produces alpha fetoprotein, no HCG, may or may not produce LDH. Choriocarcinoma only produces HCG. It does not produce alpha fetoprotein nor does it produce LDH. So these were important characteristics of ovarian tumors. Remember, you have to know the staging also and what is the approximate staging for each stage. Next, coming to the topic of vulva. Now remember, vulva is a very favorite topic, not only for your part 1, even in part 2 and part 3. So please don't forget everything that you have read about the vulva. Now, which is the most common histological type that constitutes vulval cancers? So you have squamous, basal cell, Merkel cell, adenocarcinoma and melanoma. Remember, it is squamous cell that is the most common histological type of vulval carcinoma. Now, vulvar carcinoma is only 3% of all genital cancers in the females. It is an uncommon malignant neoplasm. Among that, squamous cell carcinoma is the most common. In decreasing order of frequency, you have squamous cell carcinoma, then you have Bartholin's gland tumors, basal cell carcinoma, malignant melanoma, sarcoma, adenocarcinoma, and then verrucous, which is the least common. The other type of questions are asked about lichen sclerosis and lichen planus. So you have a 60-year-old lady who is presenting with erythematous erosive lichen planus on the vulva, and which is the type of cancer that is likely to be associated with lichen planus. So remember, again, squamous cell carcinoma is the most common histological type, and this is associated with lichen planus as well as with lichen sclerosis. With lichen planus, we know that lichen planus is an inflammatory disorder and it manifests on the skin, on the genital area and the oral mucous membrane. There are 3 types of lichen planus: classical, hypertrophic and erosive. So the classical one, you will find papules on the keratinized anogenital skin with or without striae and on the inner aspect of the vulva. Hypertrophic is rare and it affects the perineum and perineal area, and it presents as thickened warty plaques. As the name suggests, it is hypertrophic. It can become ulcerated, infected and painful. Erosive is the most common subtype to cause vulval symptoms. Okay, and in women, those who have lichen planus, 3% of them are found to progress to carcinoma of the vulva. With lichen sclerosis, the association is 5%. Next, coming to BRAA gene. So you have to remember the incidence of CA ovary and CA breast with BRCA1 and BRCA2. Now remember, BRCA1, BRCA2, the inheritance pattern is autosomal dominant. With BRCA1, The risk of ovarian cancer is around 63%, risk of ovarian CA breast is 85% up to the age of 70. With BRCA2, CA ovary 27%, CA breast 84% up to the age of 70 years. So take home message is, with BRCA1 and BRCA2, the risk of CA breast is almost equal, 84 to 85%. With BRCA1, more risk of ovarian cancer, 63%. With BRCA2, 27% risk of ovarian cancer. The other syndrome that you have to remember is Lynch syndrome. In this, the risk of CA ovary is 10 to 12%. Risk of CA endometrium is 40 to 60%. Now coming to Lynch syndrome. So there is a high risk. We know that Lynch syndrome has a wide variety of cancers. So which is an uncommon cancer, or which cancer the person with Lynch syndrome will not get? Well, the answer is bone cancer. Okay. With Lynch syndrome, the risk of colorectal cancer for women is high, especially those who have the MSH6 mutation. And you have early onset cancers like colorectal, endometrial, ovarian, gastric, small bowel, hepatobiliary, brain, ureteric, and renal pelvic cancers. So these are all the cancers that you can have with Lynch syndrome. Remember that in females, the risk of endometrial cancer is 57% approximately. Ovarian, it is 17%. The commonest genes, mismatch repair genes that are associated with Lynch are, in order of decreasing frequency, MSH2, MLH1, MSH6, and PMS2. Next important topic is about necrosis and apoptosis. Okay, so two important things to remember about necrosis. Necrosis is something that doesn't happen very commonly. There has to be an injury to the cell, and after that the cell is not able to recover from the injury, and that is why it undergoes necrosis. And remember, necrosis will not affect a single cell. The surrounding cells also will be affected. So whenever necrosis happens, the cell membrane ruptures and it releases all the cell contents, and then at that time the organelles are not functional. Whereas apoptosis is programmed cell death. So it can happen to a single cell, and the surrounding cells are not affected in apoptosis. As opposed to necrosis, what happens in apoptosis is the cell breaks down into several apoptotic bodies, and the organelles are still functional when the cell undergoes apoptosis. Now what you have to remember is which are the genes or the factors that promote and those which suppress apoptosis. Okay, so BCL2 is believed to an apoptosis suppressor gene, whereas activated P53, it promotes cell arrest so that the cell can undergo DNA repair. If the cell cannot undergo DNA repair, then the cell proceeds to apoptosis. So P53, it helps the cell to undergo either repair, or the cell dies and it undergoes apoptosis, and BCL2, it is an apoptosis suppressor gene. Next commonly asked questions are on necrosis. So you might be given a picture and you have to identify the type of necrosis, or you will be asked in a question that this type of necrosis is commonly seen in which organs. You need not remember all the histopathology that is associated with the various types of necrosis. Coagulative necrosis is commonly seen due to infarction, and it is seen in solid organs like the heart, kidney, adrenals, or spleen. And whenever the organ undergoes coagulative necrosis, the organ or that part which has undergone coagulative necrosis, it feels hard to touch, and the organ usually maintains its shape. So here this is seen in the kidney, and you can see the typical shape of the kidney here. This part has undergone coagulative necrosis. Next is liquefactive or collicative. So this is typically seen in the brain. Sometimes it can be seen in pancreas. It is because of injury like some bacteria, fungi, or any infection that happens in the brain can lead to liquefactive necrosis. Remember, in the CNS, you never see coagulative necrosis. Then the next time is caseous necrotic or necrosis, or you can call it as a combination of coagulative and liquefactive. The most typical example is tuberculosis seen in the lungs, and it is characterized by the yellow and white cheesy debris. So caseous necrosis usually occurs when the immune system and the body, it cannot remove the foreign noxious stimulus that is there. So what happens is the cells, the foreign noxious stimulus is not able to be removed or destroyed by the body. The cells enclose this obnoxious or the foreign stimulus. They form giant cells, and these giant cells all they coalesce together, and this gives rise to caseous necrosis. The next is fat necrosis, commonly seen in tissues which contain a lot amount of fat. So seen in pancreas and the breast, can be seen in the omentum also, and it is typically seen because of a destruction of fat due to enzymes. The other type of necrosis is gangrene. So remember, gangrene is not typically a necrosis, but it is a clinical term that is used to describe the changes that are happening in the tissues. So gangrene basically occurs because of ischemia. It can be dry or wet type. So dry gangrene typically is an example seen in frostbite. Now whenever there is bacterial infection, so this bacterial infection, it gives rise to liquefactive necrosis, and then the gangrene that happens is called as wet gangrene, typically seen in the upper or lower limbs. Then you have fibrinoid necrosis. So this is associated with vascular damage. Typically there is deposition of immune complex. Now this deposition, it leads to inflammation, and because of the inflammation, fibrin is leaked out of vessels. Now this fibrin under H&E stain, it has a typical bright pink appearance, and so that is why the pathologists, because it looks very similar to fibrin, the pathologists call it as fibrinoid necrosis. You also have to know something about cell adaptation to injury. So what are the different adaptations that the cell undergoes whenever it is subjected to any injury or to any obnoxious stimuli? Okay. So if this is the normal cell here, atrophy means a decrease in the cell size. Alright. The cell number remains the same, but the size of the cell is decreased. So this is atrophy. Hypertrophy means there is an increase in the cell size, whereas hyperplasia means the number of cells is increased. And metaplasia means one type of mature cell is converted into another mature cell. Okay, whereas dysplasia means that there is disorderly growth of the cells. Alright. Now we are interested basically in dysplasia that happens in the cervix. Okay, so in the cervix we know that there is something called as a transformation zone, where you have the columnar epithelium which undergoes metaplasia, and this columnar epithelium becomes into normal squamous epithelium. Why does it happen? Because this columnar epithelium, it is exposed to the acidic vaginal pH, and these columnar cells, they turn into normal squamous epithelium. Now if at the time that they are undergoing metaplasia, they are exposed to some viral agents, most commonly HPV, then these cells, instead of undergoing metaplasia, they turn dysplastic. Okay, and then you have CIN 1, 2, 3. If this person particularly is not having good immunity, or this CIN is not diagnosed in time, then it progresses on to form invasive cancer. Okay, important point to remember is that transformation zone is the most common area where pathological changes are seen in the cervix. It is the most common area where you can get invasive cancer as well as dysplasia. While we are on the topic of dysplasia and CA cervix, let us have a quick look at the HPV primary screening pathway that is there in UK, because you are asked questions on that. So which are the HPV viruses which are high risk? So they are number 16, 18, 31, 33 commonly seen. The others like 35, 39, 45, 51, 52, 56, 58, 59, 66 and 68 are also high risk HPV, but they are a little bit less common. So nowadays in the UK, instead of doing pap smear as the primary screening test, it is HPV that is done. The first invitation is sent at the age of 25 years. And the routine recall is from the age of 25 to 49 years, it is 3 years. From 50 to 64, it is 5 years. Anyone undergoing an HPV, and if the sample is inadequate, a repeat sample is taken in 3 months. Okay, so let us see the follow-up quickly. What happens? If HPV is negative, the woman is called for a routine recall. If HPV is positive, then a cytology is done. If cytology is also abnormal, the woman directly goes for colposcopy, and then according to what are the findings at colposcopy, the further management is done. Now, if a woman is HPV positive but cytology is normal, then she is called for an early recall in 12 months. Remember, normal recall is after 3 years. But because her cytology is normal and HPV is positive, she is called for an early recall. At the early recall at 1 year, again an HPV is done. If this HPV is negative, then she goes back to the routine recall. If at the early recall HPV is positive but cytology is normal, again she is called for an early recall in 12 months. If HPV is positive and cytology is abnormal, she goes in for a colposcopy. Okay, remember, anytime HPV positive, cytology is also abnormal, she directly goes in for a colposcopy. Now at the early recall in 3 months, again if HPV is negative, she goes for a routine recall. But at the early recall at 12 months, if again HPV is positive, cytology may be normal or abnormal, she goes in for a colposcopy. So this is in short about the HPV screening pathway in UK. Another hot topic and always a source of confusion is the coagulation pathway. So which are the factors that remain the same, which are the factors that increase, which are the factors that decrease, is always a source of confusion. Remember, this is a UK based exam, always follow the RCOG guidelines. Okay, so according to RCOG, factors 2, 5 and 11, they remain unchanged. Okay, so platelet count, we know. Remember, I am talking about pregnancy. Okay, so pregnancy is basically a hypercoagulable state. So any of the factors that promote coagulation, the concentration of those factors is going to be increased. Platelet count is decreased in pregnancy not because production is decreased, but because there is hemodilution of pregnancy. That is why the count decreases. Factors 2 and 5, they remain the same, whereas fibrinogen, factor 7, 8, 9, 10, 12 and von Willebrand's factor, they increase. Factor 11 remains the same or it might decrease. Factor 13 increases or decreases. Antithrombin remains the same. Protein C remains the same or it might increase. Then protein S decreases. Heparin cofactor 2 increases and D dimer increases. This is a very important chart. So please pause the slide and go through the chart again. Now next, in benign gynec disorders, endometriosis is again a very favorite topic. The commonest question asked is, which is the most common site of endometriosis? Remember, it is ovary. In descending order of frequency, you can get endometriosis in the uterine ligaments or the uterosacral ligaments, then the rectovaginal septum, the cul-de-sac, pelvic peritoneum, serosa of large and small bowel and appendix, mucosa of the cervix, vagina and fallopian tubes, and laparotomy scars. Next, coming to inflammation. So you have to remember which are the mediators that are involved in wound healing. So tumor necrosis factor, vascular endothelial growth factor, transforming growth factor beta, thromboxane, all of these are involved in wound healing. Okay, pause the slide here and please go through all the factors that are involved in wound healing, because this is a very commonly asked question. Now next, coming to sepsis. So you should know the definition of sepsis. severe sepsis and septic shock, because questions are asked on this. Sepsis, basically whenever there is infection in the body and you get systemic manifestations of infection, very commonly fever, you can get tachycardia. So these are the systemic manifestations of infection. What is severe sepsis? Whenever you have sepsis and sepsis induced organ dysfunction or tissue hypoperfusion. So in the CNS you can get it in the form of convulsions, there could be altered sensorium or the person is confused. In the lungs, if there is a septic focus, you can get a pneumonitic patch. Then the kidneys, you can get hypoperfusion leading to oliguria. Okay, in the coagulation system, you can have disseminated intravascular coagulation. Septic shock. So whenever there is tissue hypoperfusion and this persists in spite of adequate fluid replacement therapy, then you call it as septic shock. Now you should know a little bit about the sepsis 6 bundle. Okay, so these are the things that you have to do in the first hour immediately after sepsis has been diagnosed. We commonly remember it as 3 things to give, 3 things to take. Okay, so the first thing that you have to do is you have to give oxygen to keep the saturation above 94%. Then you take blood cultures, give antibiotics, give broad spectrum antibiotics only after cultures have been obtained from various places. We will see which are the places from which you will take a culture. Then after giving antibiotics, you have to give fluids if there is hypotension. You have to measure the lactate levels and then you have to measure urine output. Okay. So the appropriate investigations would be you can take a blood culture. Depending on what are the signs and symptoms of the patient. If she is complaining of throat soreness, you can take a throat swab. If she has dysuria, take a midstream urine sample for culture and sensitivity. If she has vaginal discharge, take a high vaginal swab. If she has CNS symptoms, CSF has to be obtained. Remember, all these have to be obtained prior to starting antibiotic therapy. And to know what is the MRSA status of the patient, a pre-moisten nose swab is sent for testing. So these were all the important points that you have to remember in pathology. I hope you have found the video helpful. Thank you for watching and good luck to you for your exam. Thank you once again for watching.